All right, I've got 4 o'clock, at least Eastern time exactly. So we are going to go ahead and get started. We've got a great group of people and a couple of awesome speakers joining us today. So we want to get right to it. So my name is Laura Santurri. I'm the Executive Director of the Interstitial Cystitis Association. I want to welcome you to our September webinar in our monthly expert speaker series. Super excited to have you here and super excited to be covering this topic because we get asked about it all the time. So folks may notice that their cameras and microphones are off. We'll actually adjust that for the Q&A. You're welcome to put questions in the chat, but in the Q&A session, we'll also set it up so you can raise your hand and ask a question as well. We are recording this session, so don't feel like you have to take frantic notes. This recording will be available on the ICA's YouTube channel probably in about 1 to 2 days. It just takes a little bit of time to process it, but we'll get it up there with all of our other recorded webinars from our speaker series so you can come back to this, or if you can't stay the whole time. Quickly, I just want to remind you about the ICA as the host of this speaker series. In addition to being the only national nonprofit in the US dedicated to this community, we've been around for over 40 years. I think what also makes us special is that we are led by a group of people who care very much about this community. So we have staff, we have student interns, we have a fantastic group of board of directors and a medical advisory council. And all of these folks are either people living with IC, friends and family of people with IC, or healthcare providers who provide care for this particular community. We also work really hard to provide advocacy, education, and community, and I won't read these to you, but I do want to highlight that we are on the Hill regularly and advocating for research funding, desperately needed research funding to better understand this condition. We provide a variety of types of education in addition to this monthly speaker series, and we've got some great mechanisms through which we try to create community. In addition, we've got our brand new podcast that just launched. I encourage you to check that out. That's on YouTube and Apple Podcasts. So just a quick reminder, a couple quick reminders for folks who might be new to Google Meet. If it's easier to follow, you can actually use the closed captions. That's available just by clicking the little button at the bottom that says CC in a box. It's remarkably accurate, so if it's easier for you to follow, you can do that. In addition, you can provide little reactions if you want a thumbs up, or hopefully not too many thumbs down during the session. We also have our chat feature, and I would welcome you at any point during the webinar to go ahead and put a comment or question there. We will absolutely come back to those during the Q&A session. So if you think of something as our speakers are talking, please feel free to put it in there. You can also adjust your settings at any point, especially if you want to adjust like what speakers you're using. If you can't hear as well, there's a whole set of settings in Google Meet that you can adjust throughout if you need to. So I am going to get right out of the way here. So I'm going to stop sharing. I'm going to bring up the speaker slides, and then I want to introduce these amazing folks. All right, so let me introduce our amazing doctors who have joined us today. So Doctors Eilber and Scott are board-certified urologists in the Los Angeles area with additional board certification in urogynecology and reconstructive pelvic surgery. They are also certified menopause practitioners through the Menopause Society and co-authors of A Woman's Guide to Her Pelvic Floor, What is Going On Down There, which I need to pick that up. Their passion and dedication for women's health led them to become consultants for Femetry, a supplement for bladder symptoms associated with IC, menopause, and other genitourinary conditions. They're also a really important corporate partner with the ICA. They help us provide services just like this for free for our community. And they are also involved in research to improve care provided to patients with IC and are strong advocates for patients with chronic pelvic pain. So without further ado, I'm going to turn things over to our awesome speakers.
Thank you so much. I'll let Dr. Scott kind of give herself a little bit more intro when it's her time to speak. But number one, I want to say thank you to Laura and the ICA for hosting this. I'm sure as everyone unfortunately is aware of on this meeting that it is an orphan disease with not as much attention as needs to be paid. And I'm going to just add on, not only did we do research for IC, but I have personally catheterized myself for an IC study and allowed one of my colleagues to get a suprapubic aspirate. And as we're doing this, I'm asking my colleague who is hosting the study, I'm like, this better be IRB approved, because if I get some kind of like medical problem from this, I'm going to be really upset. But I also am a firm believer that everything should have a story. And the reason that Dr. Scott and I really got involved with interstitial cystitis is, number one, we're both very passionate women's health advocates, but number two, we were just seeing a lot of women with chronic pelvic pain, bladder symptoms that were not explained. And some women were correctly diagnosed with interstitial cystitis, some were not. And then you come to find that there really aren't, you can really help people, but you just have to listen to them and be open-minded. And also one of the reasons we got involved with Femetry was we just saw an inordinate number of people managing their own IC symptoms, with diet and supplements. And so we, wanted to put together what we knew from experience and just from the available research. But to make a long story short, so I can just jump on in, because of the demographic we take care of, we also ended up finding ourselves managing a lot of hormones. And I'm sure a lot of the people also on this meeting have found that there are either people who are very anti-hormone, unfortunately, or who are trying to maybe sell you some snake oil and tell you all these tests that don't necessarily need to be done. So this next hour is really for all of you. We're here just to be a springboard so that you can think of questions and ask whatever you want to. So although we do have some slides, we're not going to bore you with a canned talk. It's just to help prompt the conversation, and we will have the Q&A, but I encourage you to at least write them down so you don't forget what they are, because invariably, if it's like when you go to the doctor's office, you forget until you get to your car. All right. So with that, let's just jump right in. And let's talk about estrogen and the urogenital tract. And why in the heck is estrogen even involved in the urogenital tract? And try not to be too gross with medical pictures, but you have to understand where we as biologic females come from in terms of hormones and the urinary tract to understand why things can really go amok when you either become perimenopausal, menopausal, are being treated for certain diseases, or taking certain medications that can affect our hormonal balance. So the female genital and lower urinary tract arise from something called the urogenital sinus, which in the simplest terms is kind of like a funny little hole that under hormonal influence develops into things like our clitoris, the urethra, the lower part of the vagina, the vulva, which also includes the labia minora and labia majora, also in layman's terms called the lips of the genital area, and then also in the area, not the anus itself, but that's just on the picture. So anything that can lower or maybe even elevate hormone levels can affect our lower urinary tract. So it's not your imagination. You're like, wait a minute, I feel like right before my period, I'm always prone to UTIs. Or I was fine up until I noticed that my menstrual cycles were becoming a little irregular. And then I started having all these vague symptoms. Oh, and by the way, you got 20 doses of antibiotics and now we gave you interstitial cystitis, but we'll talk about that in a moment. So estrogen is extremely beneficial for the genitourinary tract, and Dr. Scott will touch on what is called genitourinary syndrome of menopause. So estrogen promotes vascularity, so it actually keeps things well vascularized with normal blood flow. If you were to look at the vaginal lining of a woman who is premenopausal versus postmenopausal, not taking any hormones, it's literally like a healthy appearing, what you would imagine the lining of the mouth is. It's kind of red, kind of healthy looking versus literally pale and dry and pink. Back in the day, we called that atrophic vaginitis, which we also have lots of mean names for women. Like if you're pregnant over 35, you're a geriatric pregnancy, but we'll get into terminology later. Yeah. And it also, because of the vascularity, that's what also makes natural lubrication. So when a woman is aroused, the normal blood flow should increase. It is the increased blood flow that kind of forces the transudate or the watery part of the blood through the vaginal canal, and that's what makes our lubrication. So when you don't have normal vascularity because of lack of estrogen, that is why you start to notice, I'm really dry. When I have sex, it feels like, oftentimes literally what patients will tell us, it feels like razor blades. It feels like sandpaper. I don't know about you, but after perimenopause, menopause, or whatever can cause your hormones to go down, your libido's already down. So the thought of having sex with sandpaper really isn't very exciting, no pun intended, to anybody. But estrogen also promotes skin and collagen turnover. The lining of the vagina is an epithelium, which is just the medical term for skin. So that's why if you don't have estrogen, just like if you don't keep your regular skin healthy, it will thin over time. The lining of the vagina sheds cells also like the rest of our body. The cells that are shed through different processes literally are the food for the good bacteria of the vagina. So when the vaginal wall becomes thin, the good bacteria literally starve, which is why many women also say, I never had a problem with bladder infections until I became perimenopausal or menopausal. So then it also becomes extremely confusing. Am I just having these vague UTI symptoms because of lack of hormone, or am I really having UTIs? Sometimes it's both. Because estrogen helps to promote the normal skin and collagen turnover, it's that kind of muscle tone and normal collagen that causes the musculature of the vaginal wall, albeit it's a thin layer of muscle, to keep its tone. That's how we also have folds in the vagina, something that most people don't know. When a woman is aroused, not only is she normally get lubrication, but the vagina actually expands and increases in girth. That's why sometimes you might start with sexual activity, it's not so comfortable, and by the end you're like, oh, actually, not that you're not feeling it at all, but it just feels much more comfortable. So when there is lower estrogen, unfortunately, there is decreased lubrication. There is thinning not only of the vaginal lining, but also of the labia and the rest of the vulva. The vagina can become shortened and lose its ability to expand. So intercourse becomes painful, not just because it's dry, but because it also doesn't expand like it's supposed to be. And low estrogen can be due to a variety of causes. And I always put peri in parentheses before menopause. It is really amazing that every woman who lives long enough will go through menopause. And yet, why is it in the year 2025, we're finally just starting to pay attention to this? And perimenopause, there's not really a marker. So menopause, by definition, is no periods for a consecutive 12 months, assuming a woman still has a uterus where she can bleed. Perimenopause doesn't really have a definition and can sometimes start as early as someone in their 30s, maybe in their mid-30s, but this also explains why a woman is much less fertile at 35 than at 30 than at 25. Our hormones are already on a decline, and if that wasn't depressing enough, we are born with 1 million eggs, and by the time we're born, that number is already half. So it's really amazing how much the female body changes over time. Other causes of low estrogen, postpartum, and I'll show you a graph in just a moment what happens with our hormones. Breastfeeding, oral contraceptive pills, those things keep our hormone levels low. So for instance, breastfeeding, for the same theoretical reason you can't get pregnant when you're breastfeeding, it's because our hormones are totally low, which is also why poor woman just had a baby, her hormones are already amok, she's breastfeeding for a long time, now her vagina hurts, now she's having relationship issues because she doesn't want to have sex. Like, there's just no justice for us, ladies. All right, and then other medications and also other conditions. So people have certain autoimmune diseases like Sjogren's syndrome, where people are just overall dry. A lot of antihistamines. We have chronic allergies where we're taking things over the counter or don't realize that that can actually dry out just about everything. So what happens to our estrogen levels over time? Just for a little review, or maybe some people don't know what it is, but during the normal menstrual cycle, so here's that kind of purplish, or I don't even know what color that is, violet line of the estrogen, which peaks out right before there is this surge of LH, or luteinizing hormone, which is what triggers ovulation. The green line, which is progesterone, that's pretty low until after ovulation, and progesterone peaks if a woman becomes pregnant. the progesterone level continues to increase, and that's what helps to maintain a viable pregnancy. So if there is no fertilization, all the hormone levels just decrease and we start all over again. So you can see where it's not, again, your imagination, where I really feel like every month I have certain symptoms that really just drive me crazy, whether it's I see symptoms feeling like a UTI or even getting a UTI, even getting vaginal infections, because also with the decrease in estrogen, the vaginal pH, which is normally very acidic, can take a little bump. So when the pH is higher, which a higher pH is more alkaline or less acidic, that can make us more prone to infections or an imbalance that doesn't feel quite right because it's not our normal pH. So the reason I put this slide up is you can see that on the left is postpartum hormone levels and on the right is menopause hormone levels. And sadly, they're not terribly different. So when you're on this left side, when you're breastfeeding, your hormones can kind of go up and down. But I do think that, and I have no data except for my own observations, that women are postponing childbirth later and later and using assisted reproductive techniques. So probably a lot of women are already perimenopausal when they get pregnant. I do believe that women who breastfeed for a year, 2 years, 3 years, I think it kind of accelerates the perimenopausal symptoms because you're not really going back to your normal system. So listen, I breastfed all my kids. I do think at some point we need to do some kind of research to say, hey, it's not ideal for you to breastfeed past this point, or maybe we need to give you some supplemental vaginal estrogen or something. But we see a lot of women with genital urinary syndrome menopause symptoms. And again, Dr. Scott will talk about that simply because they're breastfeeding. And you assume because they just had a baby, their hormone levels aren't so off. But in fact, even a 25-year-old who is breastfeeding is going to have low hormone levels. And then I am going to transition over to Dr. Scott.
All right. Sorry, we didn't remove that section. So
I'm sorry.
I didn't update the slides. But so as Dr. Eilber was mentioning, genital urinary syndrome of menopause. This is really something that we see so much as urogynecologists, and particularly important to educate anyone with IC about. Because if you're premenopausal, it will impact you later on. And if you're postmenopausal, probably there's a good chance it's impacting you as well. So what is this? Genital urinary syndrome of menopause is the constellation of symptoms that occur due to mainly the decreased estrogen, maybe a little bit of the decreased androgen or testosterone that occur during peri and postmenopause time period. So Dr. Eilber already kind of detailed how important estrogen is for the urethra, the bladder, the vulva, and the vagina. They love estrogen. It helps keep that tissue really healthy and happy. When our hormones start to fluctuate during perimenopause or then drop during the postmenopause period, we start to develop all these symptoms. And when I say we, studies have actually shown up to 80%, honestly, probably even more of women who are postmenopausal will experience these symptoms. So these include vaginal dryness, decreased lubrication or painless sexual activity, recurrent UTIs. Dr. Eilber detailed that in why the vagina loves estrogen so much in terms of preventing UTIs. So the bacteria that's really helpful for maintaining a healthy vagina are the lactobacilli. So you may see this product in like a lot of probiotics, especially that are designed for recurrent UTIs or recurrent vaginal infections. Lactobacillus is really protective. It helps to keep the vagina nice and acidic. And this chases away the E. coli and the other pathogenic bacteria that cause a lot of the UTIs. So again, we lose our estrogen and we lose our lactobacilli. We're more prone to UTIs. The GSM also includes irritation or burning in the vagina, the vulva, the urethra, painful urination, urgency, frequency, and as Dr. Eilber mentioned, a lot of patients say, I just don't feel right down there. I feel sandpaper or like razor blades. And so this chart kind of details like the anatomy, but again, all these structures are lined with estrogen receptors. So we lose our estrogen and we start to develop all these symptoms. So how do we diagnose GSM? We really don't need anything other than clinical symptoms and to know that you're in that perimenopause or postmenopause time period. Although on exam, we can observe findings that are confirm the diagnosis. So we can have reabsorption or kind of thinning of the labia majora or the lips of the vagina. The introitus or the opening can kind of shrink and become smaller. And then we see changes, the tissue becomes a little bit more like white or pink and less red and healthy in appearance. Unlike a lot of the more common menopause symptoms that many people are more familiar with, like hot flashes, night sweats, mood instability, the symptoms of genitourinary syndrome menopause can often persist even after the 5 to 10 years after you go through that menopause transition, whereas night sweats, hot flashes, those will typically subside. And in fact, there are also many women who don't necessarily experience GSM during menopause, perimenopause time, but then they develop at age 60 or 70. So these are all important things to keep in mind, again, because GSM is not really talked about by many doctors. It's certainly not screened for. A lot of our research shows that. We know that many women are unaware of the condition or even of treatment options because they're just not really asked about it. All right. So managing GSM, or actually I should go back for 1 second, sorry. So just looking at this list, you can really see how symptoms of GSM can mimic IC, absolutely. So we were just talking about how, if you are diagnosed with IC right around 45, 50 years old, maybe you're treated, you're given vaginal estrogen, everything gets a lot better. It's certainly important to question and ensure you've really received the correct diagnosis. Was it just GSM or was it really IC? Now, that being said, patients with IC can absolutely have worsening symptoms around this time. And it could be GSM on top of your IC, but it could also be that decreased estrogen just making your IC symptoms worse, because estrogen is so important for maintaining the gag, protective layer of the bladder, and the urethra. So you could certainly just be having a flare of your IC symptoms. So important things to keep in mind. All right, so for management, we do have a nice toolbox of options, and this is for just general GSM. For patients with IC and GSM, again, we need so much more research, but a lot of these will be applicable too. So we have local non-hormonal therapy. This is a very decent place to start. If your symptoms are more severe, you probably won't get that much benefit, but it's certainly very reasonable, especially if someone has any fears about hormones. So vaginal moisturizers can be purchased over the counter. A lot of them will contain ingredients like hyaluronic acid. They're just going to be really helpful for moisturizing the tissue and helping to reduce some of those symptoms. Lubricants, so these are used during sexual intercourse. It's important to distinguish between the two. You don't want to use a lubricant that's designed for sexual activity as your daily moisturizer. You probably would benefit from using both. So your daily moisturizer, same way you take care of your face, you have to take care of the vulvar and vaginal tissue too, and then layer on the lubrication that you need during sexual activity. Now, vaginal laser, you may have, this kind of become more of a hot topic. It's not FDA approved for genitourinary syndrome menopause. So I should say that, but there is a lot of research to suggest that it can be helpful as a non-hormonal local therapy. And we definitely see some patients benefit. So the same way that people use lasers on their face to improve the collagen, elasticity, the strength of the tissue, it can do the same for the vaginal and the vulvar tissue. For local hormonal therapy, this is really going to be our best option for treatment of GSM. The mainstay being a vaginal estrogen. And you can use this in a cream, a vaginal suppository, or a ring. The cream is, I think, what most people typically start with. Some people find it a little messy, but it really works well because it gets the vaginal canal, but also the vulvar tissue. Suppositories, again, are nice if you feel like the cream is too messy, but sometimes they don't get the vulvar tissue as much. And then the ring is really nice if you just don't want to have to mess with anything down there. And it's just something you can change every 3 months or have your doctor change for you. DHEA is another newer local hormonal therapy. So DHEA is the precursor to both estrogen and testosterone. And this is usually applied in the form of a suppository nightly. And this can really help with GSM by providing some estrogen, as well as probably some testosterone too, because some of the DHA is turned into testosterone as well. For our systemic non-hormonal therapy, the main option here is ospemifene. So this is a SERM, a selective estrogen receptor modulator. And this is a really neat medication because on some tissues, it's an agonist and mimics estrogen, whereas on some tissues, it's an antagonist. So interestingly, in the vaginal vulvar tissue, it's an agonist, so it helps mimic estrogen, whereas in the breast tissue, it's an antagonist. So this can be a good option for patients with a history of breast cancer, even though they can safely use a local hormonal therapy, if for whatever reason they or their oncologist don't feel comfortable, this is a nice non-hormonal therapy. And then finally, we have our systemic hormonal therapy, or HRT, hormone replacement therapy. So this isn't used for the main indication of GSM, but can help. So the main indications for hormonal replacement therapy would be more of the hot flashes or vasomotor symptoms, or prevention of osteoporosis and bone protection. So this would include estrogen plus or minus progesterone if you have a uterus, and the estrogen can be in the form, so many different forms, pills, patches, probably the most common, sprays, creams, and then progesterone most commonly as a pill. So some important things about systemic hormone replacement therapy: even if you are on this therapy, you still may need to add some local therapy to the vagina and the vulva. So this could be in the form of a vaginal estrogen cream, for example. We definitely see some patients where they start their systemic hormone therapy, their night sweats, their hot flashes get a lot better, but they're still really bothered by the dryness or the painful sexual intercourse. And then they do a lot better when we add a local vaginal estrogen. Now, just a word on hormones. So this probably our biggest barrier to treating GSM is just the fear of hormones. And where did this come from? So this really started from the Women's Health Initiative. This was the big study in the early 2000s where they said, okay, let's look at how safe and effective hormone replacement therapy is for women, estrogen and progesterone. And what happened was they ended up stopping the trial early because they were concerned that it was causing breast cancer, heart disease, and strokes. So basically, at that point, hormone prescribing therapy went from extremely high to almost nothing because everyone was just so fearful. Fortunately, experts have really started to reevaluate the study and really look at the data and are really starting to realize that the study was very flawed, and actually hormone replacement therapy is very safe and very effective. So this has been really exciting for us as doctors in this field because now we're starting to have a lot more conversations and provide women with tools that are so helpful. So I would definitely encourage, if you do have fear of just hormones in general due to breast cancer, heart disease, or stroke, to really have more in-depth conversations with your doctor, because probably they'll be able to, at this point, provide you with enough evidence to convince you that if you would really benefit from hormones, it's worth it. It's worth a try. In addition, the really nice thing about vaginal estrogen, specifically to treat GSM, is that most of it remains locally in that tissue. So very little, if any, is going to be absorbed systemically. In fact, many guideline statements from the American Urologic Association or the Menopause Society all state that even women with a history of breast cancer can still very safely use vaginal estrogen. Of course, we always recommend talking to your oncologist, make sure everyone on your team is on board. But that's another important education point for many women with history of breast cancer, because they tend to suffer pretty significantly from genitourinary syndrome of menopause, specifically if they've had to take an estrogen blocker. That tissue is kind of even more deprived. So just a couple of points there about hormone therapy and fears. In terms of, as I mentioned, treatment for GSM specifically for IC patients, again, we really need more data, but there's certainly no research to suggest that it would be harmful or necessarily trigger flares. There may be some concerns given the fact that estrogen can activate mast cells, and there's probably a number of people with IC who have worsening symptoms due to increased mast cells, increased histamine release, and inflammation. But again, we really don't have evidence to suggest that. So we certainly recommend to our patients with IC that we think there could be a component of GSM involved. Absolutely, it's worth a try for either our local non-hormonal or even hormonal options for treatment. And with that, I think that's all we have for our slides, but happy to take any questions.
Yeah, there's
Thank
a lot
you.
of chat already. It's great.
Yeah, so I was going to say, I'm going to stop presenting so that people can see you better and see each other. And do you both have access to the chat okay, where you can see? Got some fantastic questions in here. So I'm going to let you start with the questions. We'll start there, and then we can also go to people who might want to unmute and ask questions as well.
All right. So I'll start with when I got diagnosed, I was given Elmeron and gabapentin, and now my urologist won't let me take Elmeron anymore because I guess it causes issues with your eyes. Yes, that is true. You can always have an informed, discussion with your physician, tell them you're willing to take the risk. Having said that, in my practice, I think Dr. Scott still does it, we actually put Elmeron in the installations. So the basis of Elmeron was the same as like for heparin because the glycosaminoglycan layer. And I always had concerns about Elmeron, not just because of issues with your eyes, but because there's also risk of hair loss, which, can be really devastating for women also. And I would love to take credit for it, but years and years ago, I heard someone give a talk about IC and they were putting it in their installations. And I swear once I started putting it in my installations, they worked better. So that is one way around that. If you are okay to take installations and you can actually just open the Elmeron capsules and put it in that way, that's one way to do it. Or, I do think, the longer I practice medicine, you also just become more comfortable because you're practicing longer, but patients are smart people. They understand risk. And, as physicians, unfortunately, we are literally now trained to be risk averse because of medical legal issues. And I do think it is sometimes the detriment of our patient care. So if you really have an open discussion with your physician, say, look, I was doing really much better with the oral Elmeron. I understand those risks, but I've been taking it for so long and I've not had an issue. And if they're not willing to continue it and you really want to go that route, then you can also always get a second opinion and see if someone will be willing to give it to you. But that definitely, I think, is an excellent example of just a physician and a patient trying to make, shared decision making.
I absolutely agree with that. And I have had a few patients like this where their symptoms were so stable and they were doing so well on Elmeron, they didn't want to stop. And so we said, okay, go see an ophthalmologist, make sure you see them every 6 to 12 months, and they're still happy. So yeah, definitely.
Yeah, the risk, it's not 100% guaranteed, right? Yeah. It's a risk. So.
Exactly. All right, how do you address burning from vaginal estrogen cream? That's a great question, and another huge problem we have with patients. Unfortunately, if we don't counsel them adequately, we give them therapy and then they have bothersome side effects, they're just not going to use it. And with the vaginal estrogen, it's really, we tell patients it's indefinite that you need to use it. So once you stop using it, symptoms will probably recur. It's really unfortunate when we see women who use it for a little while, they're like, I was doing so much better, and then they come back 6 months later, well, I stopped it and now I'm a lot worse. So definitely, if it's working well, not having bad side effects, don't forget you do need to continue the vaginal estrogen. That being said, when you start it, it can certainly cause increased burning. So if you imagine a super just dry, irritated rash, like on your arm or your hand, and then you add like a steroid or whatever kind of ointment you need to add, it can definitely burn. That tissue is very angry and irritated. So it's definitely important for us to counsel patients that it can flare a little bit in the beginning, but really try to give it 4 to 6 weeks before we start to see improvement in the quality of the tissue and overall symptoms can get better. Now, that being said, I have had some patients that didn't do so well on the name brands like Estrace or Premarin, and in which case, if you think that might be you, you could try a compounded form of the cream and say no additives. Sometimes that could be helpful too.
Yeah, just to add on that, if you have a relationship with a good compounding pharmacist, or if your healthcare provider does, the pharmacists at compound, they really know which are the least irritating bases for people. Yeah, a compounding pharmacist for hormone therapy can be really beneficial. So, the official byline, of course, is from the Menopause Society is compounded hormones are not first line. And, because they're not, your compounding products are only as good as your compounding pharmacist. That's why it's really good to know your pharmacist. But there are women who just cannot tolerate the commercially available doses. Just like you talk to some women, I never could take the pill. Well, it's interesting that estrogen and progesterone are the main hormones in our body, yet there are women who just cannot tolerate exogenous forms. And I just think we're just not finding the right mix. So for some people, yes, I think that compounding is the way to go.
And then one other actually thing to add on to that would be, it may also be you could benefit like along the lines of compounding therapy, an estrogen plus testosterone. Maybe that could be helpful too, because there are a lot of androgen testosterone receptors in the vulva and the vagina as well. So that would be another thing to consider. If you've really given it like 6 weeks and you've tried no additives, then maybe adding the testosterone could help.
Sorry, last little thing. The most common form of estrogen that is prescribed is estradiol. But the reason why there's estradiol is there is estrone, or like 1, which is more predominant during menopause. There is estradiol. There's estriol, which is also much more common during pregnancy. And estriol, though, is the weakest form. So I have some patients who are so sensitive that I will start them on compounded estriol, help them kind of build up, and then they can maybe tolerate the commercially available estradiols. But yeah, I do think that is an important thing to know is there are different forms of estrogen. I'm maybe getting ahead of myself, but anecdotally, we have lots of women who say, the only time I ever felt good with my IC was during pregnancy, or vice versa. And then we try to replicate pregnancy by giving women progesterone because that's a predominant hormone, and yet they don't get better. And I actually was at a menopause conference recently, and a physician who actually is doing research on cognitive function menopausal women, it's probably the estriol is what makes pregnant women feel well, because it's a different form of estrogen. So in fact, she's studying estriol and cognitive function, which I actually think is so brilliant, because we always just look at estradiol and progesterone, but we're not looking at the other forms of estrogen, which I think is really quite fascinating. So if you really just don't tolerate, and there are some people, even though the vaginal estrogen, it's been studied, should not be absorbed in the bloodstream in any significant amount. If your vaginal lining is really just so thin, then you might need to start on a very low percent estriol and then kind of work your way up. All right, can I start with the next one? Do doctors think that taking a lot of antibiotics are a cause of IC? I think there are some of us who believe that there are probably certain forms of IC that are created by that. And this goes back to at the beginning of this webinar when I talked about I catheterized myself and did some other things. It actually has been shown that the microbiome diversity is lower in IC patients than people who don't have IC. And, the question is, which came first, the chicken or the egg? Did you really have a UTI? Because lots of IC patients will tell you the day their symptoms came on, it was just like a UTI. Maybe they felt better the first time around the antibiotics, but the subsequent times they didn't. So did they really have a UTI and we gave them IC, or they had IC and the antibiotics just made it worse? But similarly, for irritable bowel syndrome, they find the same thing. That is a loss of diversity in the gut. So look, nobody really knows the exact reason why, but you can't ignore the fact that there are so many people with IC who are treated with so many antibiotics. And again, you don't really know which came first, the chicken or the egg, but I just loathe when people come in, they've been treated like 20 courses of antibiotics. I'm like, well, when it didn't work the first 5 times, like, why'd you think it was going to work the 6th time? Dr. Scott, any comments on that?
Oh yeah, I definitely agree with those thoughts. And I know like we've shared lots of discussions about just our anecdotal experience, and we see it a lot. All right, at last, after 30 plus years of IC, my Hunter's ulcer was removed, and with amitriptyline and hydroxyzine, I was living almost normal. This summer, I was diagnosed with early stage breast cancer. I started hormone blocker letrozole and immediately had a return of the symptoms. Is there any hormone blockers that I could take? So it's a tricky situation, but I definitely think, again, with adequate informed decision making with your oncologist, they certainly could have treatment options for you. And that could be that very small amount of vaginal estrogen. It could be a non-hormonal vaginal moisturizer, or perhaps it could be something like DHEA or even ospemifene. So I definitely think you have some options, because yeah, it sounds like the flare in your symptoms does seem to be related to that block in estrogen. And so trying to help the vulvar and the vaginal, as well as the urethra and the bladder tissue with some kind of therapy could be very helpful. And I guess also, I'm assuming you're still on your amitriptyline and hydroxyzine. But of course, yeah, considering your usual IC, like rescue medications too.
Yeah, I mean, and again, this goes back to, I think, the shared decision making. And, full disclosure, I'm not an oncologist, but with early stage breast cancer, depending on what your ER receptor status is, for sure, taking estrogen blockers can reduce your risk of recurrence. I know I've had some patients who they had such a bad reaction that they accepted the risk of reducing, or they accepted the risk of not reducing their risk of recurrence because of that. But it has been well studied that certain commercially available vaginal estrogens, the low dose ones, are acceptable to use in breast cancer patients. There was an official statement by the American College of Obstetricians and Gynecologists in 2016 stating that, after discussion with your oncologist, it, has not shown to have any kind of recurrence. So you still can use a vaginal estrogen, and maybe it's really because, and I don't know how old you are in this, but, it could be whether you're already perimenopause or menopause and just kind of like push you over the edge, that it's not necessarily, just your IC, which has been stable, but it's because you accelerated a genital urinary syndrome of menopause by taking an estrogen blocker. All right. Are there probiotics that won't flare IC? That's a good question. I mean, everybody has different flares. The thing about probiotics, it's one of those things where everything in moderation. So keep in mind that probiotics in general are live bacterial cultures. So if you take it too much and they replicate in your gut, you tend to be gassy. So I think a lot of people take probiotics because they seem like they're a healthy thing to do. But my thing is, if you feel fine, like probably just don't do it. Or if you take a lot of antibiotics, I don't think probiotics are a bad idea. But, I also think that the future truly of personalized medicine is when we are healthy and young, we test our gut microbiome, our bladder microbiome, our vagina microbiome, so that when we get sick, we know what our normal microbiome is. A probiotic that's good for one person is not going to necessarily be a good probiotic for the other. And we always talk about lactobacillus as the good bacteria, which that is true, that genus is, but the specific species, if I'm getting the correct terminology, right? There's Lactobacillus acidophilus, which is predominant, but probably the lactobacillus that is the most beneficial are Lactobacillus reuteri. There's other ones, rhamnosus. So I can't really recommend a specific probiotic that won't flare IC, because I think part of it depends on what your microbiome is. Was that a long-winded way of saying no? I don't know.
I agree. I think that comment I would add regarding probiotics is, like Dr. Eilber mentioned, if you find you're getting really gassy and bloated, then maybe take them, not every other day, maybe take them once a week. Start with once a week, start with every other day, just to make sure that those GI symptoms aren't causing a flare in, your bladder symptoms. All right, I use estrogen pessaries and felt this caused a flare. Is it likely, and why? Can I have too much estrogen? So interesting. I can think of a couple things. You know, it may just be something like mechanically sitting in the vaginal canal. Perhaps it's irritating the bladder and urethra, so that could be one thing. Even though, you know, it's such a small ring, like we really wouldn't expect it, but that could be one thing to consider. Or just that constant, you know, slow release of estrogen for whatever reason may be more bothersome to your bladder. So you absolutely can consider another form of therapy like cream or the suppository. Those could be good things to consider. Or again, maybe like DHEA. Can you have too much estrogen? Well, like Dr. Eilber mentioned, you know, everyone is so different in how sensitive they are to different formulations and types. So it could just be the mechanical ring itself. It could be the formulation or just the way it's absorbing. They could be more bothersome to you. So I would urge you, don't give up. Just try a different formulation or a different application method and see if that maybe helps.
Yeah, it might just be because you're not getting straight estrogen, right? You're getting other additives. So you may be one of those people who could benefit from, you know, seeing it or getting a prescription for a compounded estradiol with a really, really mild base. Okay, my gynecologist told me that taking oral estrogen at the age of 60 is not recommended. There's some half-truths in a lot of that. So first of all, oral estrogen is not the preferred recommended delivery system. A transdermal estrogen is preferred because it bypasses the liver, and so you actually have lower risk of blood clotting issues and other things. So that's why most estrogen is a patch. People who take the pill, or I just have patients who don't want to deal with a patch, or they claim it can't stay on, whatever it is. So those are the few people that actually give oral estrogen to, but typically it is a transdermal estrogen. So the reason why it's after the age of 60 is not recommended, and again, this is all about informed consent and having shared decision-making. The WHI study, although there were many flaws with it, what we did learn was that taking or starting hormone therapy 10 years after menopause, which the average age of menopause is 51 in this country. That's why we kind of say, think about twice starting hormone therapy at 60, because generally you've been menopausal for almost 10 years without any hormone therapy. And one of the reasons is your body, specifically your blood vessels, have changed to the degree that if you start hormone therapy later, you actually have an increased risk of cardiovascular events and stroke. And I actually talked to one of our cardiologists who specializes in hormone treatment about this. And one way to conceptualize it is when a woman is pregnant, right, you're prone to like constipation, varicose veins, because the hormones relax your blood vessels. Well, when you don't have any hormones and your blood vessels get brittle and then they get plaque on it, if you then relax them, those little flecks of plaque will come off and cause stroke and heart attack. So that's one theory that they think of why that happens. Having said that, let's say, I don't know, you've always suffered from menopausal symptoms. You just never got around to seeing the doctor about it because you're taking care of your kids, working 3 jobs to pay for the college tuition, like, you know, all women do. And you finally get to take care of yourself when everybody is off and married on their own. If you really, the first question I would ask is, why do you want to start now when you've probably already had the worst menopausal symptoms? And if someone says, well, because I want to reduce my risk of, you know, osteoporosis, this and that, you've kind of missed a little bit of the window by not being on the whole time. If you say that, you know, I've always had thinning hair, I have no libido, I just don't feel good, I still have hot flashes, then absolutely. But I think the fundamental thing to ask is, why start? And if you do want to start, it's fine. I just have to give you that whole explanation and make sure you don't have any other risk factors as to maybe why someone didn't want to give you oral, you know, estrogen to begin with.
Or if you're on, let's say you started your estrogen at age 50 and you're 60 and your doctor's trying to tell you you have to stop, that's just kind of another setting where informed consent and decision making, I think, is really appropriate, because some women are like, no, I will never stop my estrogen. I feel too good. And as long as they understand risk, then absolutely they should be able to continue it.
I'm going to die with my estrogen patch on. I'm just saying.
Same. I don't have that yet, but I'm going to.
So one scenario, though, is let's say you took hormones until you were 55 and you stopped and now you're 60. You're not really in the same risk category because you really haven't been menopausal for 10 years. So make sure, like, because I have lots of women who, in fact, I had a patient who God love her, she looks great. She's 80. She was on her hormone therapy up until the pandemic, and for whatever reason, like got lost to whatever follow-up, and she wanted to resume it. Nobody wants to give it to her because she's over 60. I'm like, okay, but you've been on it for 20 years already. You just took like a couple year break. So I put her back on it. But yeah, those, if you've been on hormones for a period of time and then you stopped, you're not really, at least in my opinion, in that kind of 10 years, no hormone therapy.
All right. You mentioned 2 medical groups that approve vaginal estrogen. Can you repeat those? Absolutely. So the American Urologic Association just came out with a great guideline statement in support of the use of vaginal estrogen for GSM specifically, so you can look at that one. I also mentioned the Menopause Society, and I'm not sure if theirs is more of a recommendation, like a formal guideline statement or recommendations. It may be more of their recommendations. I don't know if they have a formal guideline statement, to be honest with you. Probably not, but in all their literature, that would be another good resource to look at. They have so much research on their website with lots of evidence for efficacy and safety. ISWICH, I'm not sure if they have a formal guideline either, but I would say the American Urologic Association guideline statement would be a great resource with all the evidence.
Yeah, I think most people recommend it. It's just, I think last year, the American Urologic Association came out with an official guideline just because everyone was kind of doing it. So it was probably just good to have a guideline for people who weren't necessarily comfortable doing it. So at least they had something to guide their treatment. Yeah. Okay, I have to take this one. I've been seeing ads pop up on my social media for the Kiwi vibrator, which is designed specifically for painful penetration. Do you recommend this for postmenopausal IC patients? So Dr. Scott in our group, we actually did research on vibrators in general a couple years ago. It's actually published. Like one of them was, is it time for doctors to start prescribing vibrators? So back in the day, well, first of all, if people don't already know this, anyone ever wonder why it's called hysterectomy and not uterusectomy? It's because removing the uterus was thought to remove the hysteria. So another treatment for hysteria was basically the doctor, I mean, if you look at the kind of old pictures, like climaxing the woman. So then when the industrial age came, there literally were machines in the doctor's office that would do this. And as the technology got better, they started resembling more of modern day vibrators, smaller devices. But around this time, though, stag movies, which are the equivalent of today's porn movies, came out, and these stag movies would feature these what were medical devices, i.e. vibrators, and that's when they became outlawed. So vibrators actually initially were a medical device. So in urology, when a man has a prostate removal, we put him on Viagra or medication similar to it to increase blood flow because we know that blood flow is what helps things heal. Well, based on what we were talking about earlier, when you are perimenopausal or menopausal and there's lower estrogen, there's not as much blood flow. So we did a study where we had women use a vibrator regularly, whether if she climaxed, great, that wasn't the point. It was just to actually use a vibrator for a few minutes, a few times a week to get blood flow going. And we just kind of threw the net wide. And we saw improvement in pelvic pain, incontinence, prolapse symptoms, overall quality of life. So the answer to your question is, I think any vibrator could be good because it increases blood flow to the pelvic area. And this is exactly what women who are menopausal, not on hormones, need. And now for IC patients, you do have to be a little careful because, again, just like the probiotics, everything in moderation. I have also seen women over the years for pain because they either used, and we don't know what is the best setting for vibrators. We're actually trying to study that right now. But they will use it for too long on too high settings, and that clitoris has so many nerve endings that they actually end up getting like really weird symptoms, which the first time I saw this and we finally figured out, like, it will take months for it to get better, but it will get better. So just, be cognizant of that. And, if you use it on the clitoral area, I think you should probably experiment a little bit, make sure you don't get like too irritated, or you could also just use it internally. But without this sounding too weird, I'm all about women using vibrators.
Absolutely. All right, I have been taking AZA for the urgency, and it does help with the gabapentin. That's great. Like Rebecca mentioned, I too tried the vaginal estrogen, experienced major flare and IC following it. What type of hormone replacement that might be less likely, but help the painful intercourse? So yeah, as I mentioned, why could local vaginal estrogen be causing a flare? Could be maybe triggering mast cell release and histamine release. But I think there are definitely ways to play around with it. So if your main symptom is more the painful intercourse, you could switch gears and try more of, a non-hormonal vaginal moisturizer, perhaps, if your symptoms are less severe. So daily vaginal moisturizer, and then with intercourse, just making sure you have a really good lubricant. So that may be adequate for you. Maybe you can avoid the hormones altogether. Or maybe you're having more vulvar symptoms. So maybe you can try applying like a cream more just to the vulva area, where maybe less risk of absorption into the urethra and the bladder, where it could be triggering things. So I think there are definitely ways to play around with it. Again, maybe consider DHEA too, because that will be metabolized not just to estrogen, but also to testosterone and androgen, which will help the tissue. So yeah, I think there are definitely options. Again, don't give up on hormone replacement therapy if you need it, or the local estrogen replacement therapy if you need it, but maybe try the non-hormonal options first.
All right, good time. It looks like we're wrapping up. Is there a way to know whether symptoms are from GSM or ineffective treatment of vulvar skin conditions? That is a great question. In fact, I just took a patient to surgery the other day to biopsy for lichen sclerosus. So oftentimes you can indirectly make the diagnosis by how someone responds to treatment. So some milder lichen sclerosus will respond to topical vaginal estrogen, but usually you need steroids for that, and GSM usually will not get better with topical steroids. GSM also isn't in general localized to the external genitalia, which lichen sclerosus tends to affect, the labia majora and the opening, but they don't necessarily, or women don't necessarily complain of vaginal dryness. So is there a way to know in the first consultation, and she has, if there are no external signs of any skin conditions, because lichen sclerosus, lichen planus is going to look abnormal. So with totally normal appearing skin, those would be unlikely. But if someone, and it's also possible somebody has both. So if someone does have some skin changes that are consistent with lichen sclerosus or lichen planus, and they also have GSM symptoms, I will probably only know after a couple visits, where in between I'm treating them for what I think is what she has.
Yeah, I agree. You can treat with if you suspect lichen sclerosus, you can either biopsy or you can just start empiric treatment with steroids too. So either way, you could ask for, if you're suspecting of lichen sclerosus, then you could ask for a biopsy or a trial of steroids, like on top of the vaginal estrogen.
All right, so we are coming up on 5 o'clock Eastern. I want to be respectful of everyone's time. So first, let us give a big virtual round of applause to our amazing speakers. Thank you so much for both your the information that you've shared with us, but for answering all of these fantastic questions. And thank you to our attendees for those fantastic questions. I did put a link to the AUA guidelines on GSM. So if folks want to take a look at those, that's in the chat. And to wrap things up, I'm also going to put a link to our communications sign up for the ICA. So if you are not receiving communications from us, I strongly encourage you to sign up to do that. I'm just going to share a quick slide here as a reminder of all the ways that you can connect with us as an organization. Again, get signed up so that you're getting our monthly newsletter, you're getting our research digest, and you're getting information about these webinars and all sorts of other resources that we provide to the IC community. So again, many thanks to our speakers and to everyone who joined us today. What a fantastic discussion and such a really important topic. I hope everyone has a fantastic rest of your day and a wonderful weekend. Thanks all.
Thank you.
Thank you so much.